Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by AACN's award-winning online leadership course, Fundamental Skills for Nurse Managers, with information available at www.aacn.org/manager skills. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
Welcome to today's podcast. This is Andrea Schmidt, Clinical Practice Specialist at AACN, and I am joined by my colleague, Julie Miller, another Clinical Practice Specialist at AACN.
Thanks, Andrea. Glad to be here.
We are happy to have you as a guest podcast host today. So today, we're going to talk about virtual health nursing. But before we get started, think of all the terms that we know: telecritical care, EICU, virtual health, telehealth nursing. What is really the difference between all of these? So today, this is what we're going to learn about, but our focus is going to be on virtual nursing. The evidence-based benefits can impact organizations such as nurse engagement, retention, satisfaction, mentoring, patient outcomes, and the financial impact to the organization.
You know, Andrea, that's such a great way to begin this, because when I think about virtual nursing is kind of like screamed onto the area of the world in the last 3 years, basically since the pandemic. And people think virtual nursing is new because it's really been implemented most successfully in the medical surgical areas, where they're, taking tasks off of the direct care nurses and allowing them to do those tasks virtually. But really, telecritical care nursing has been around since the early 2000s. And it was very interesting to me that I recently was speaking to a colleague, and we were discussing telecritical care. And he said to me, well, that's just physicians. And I was like, no. I said, telecritical care nursing has been around since the early 2000s, where nurses are monitoring patients remotely and intervening when they see, deterioration. And I just thought, wow, there is still so much to learn and so much education that we can do around this field. So it's pretty neat, hospital leaders, they have to learn the benefit of what this can do and think beyond just the financial ROI, because sometimes this does take more money, but the other return on investment that can occur for nurse engagement, nurse retention, can offset the cost of implementing that. So I'm so excited about this, and I'm excited about our guest today too.
Me too, and I'm excited to hear him talk about how this does not replace the direct care nurse, which I think is something that everybody is so afraid of, right? So with that being said, I would really like to introduce today's guest, Paul Malito, Director of Nursing Services at the University of Alabama at Birmingham eMedicine.
Well, thank you guys. Thanks, Andrea and Julie, for having me on today. I'm so excited. I enjoy any chance we get to talk about virtual healthcare and virtual nursing. So I'm ready to get started and bring part of what we do to the masses.
That's awesome. Thank you, Paul. Well, why don't we get started by getting to know you just a little bit better? Would you tell us a little bit about yourself and your nursing journey?
Of course, yeah. Oddly enough, nursing is a third career for me. I've done many different things throughout, but came to nursing in my 30s and really was a focus on ICU nursing. So I started in cardiac surgery, ICU nursing, had an opportunity to manage a medical ICU for a couple of years, realized that I didn't know enough about healthcare. So I needed to take a step back and really dive in and learn more, and spent another 5 or 6 years learning everything I could about healthcare. Then our pandemic that you guys alluded to earlier hit, and I learned that there was more that I could do. Started looking around and found out a little bit about telehealth and applied for a telehealth position. I thought, hey, I love telehealth. I think this is great. And then I started looking into what it was, and I was like, tele-ICU? I have no clue what that is. And had to do even more research and just fell in love with what the opportunity could be with it, what the potential it had. And interviewed for the position here at UAB, University of Alabama at Birmingham, to start the tele-ICU program, and got really excited, got really involved, and we developed something special here in the state of Alabama that's just really blossomed into more than we ever could have imagined. So, it's funny in nursing, they always say that where you start is not where you end. You can go anywhere, and we are. We brought the future into the now, and I'm so excited to just continue to grow with that.
Thank you, Paul. That is just like I love hearing your journey into nursing and where you've landed. So, going back to what I mentioned in the introduction, all these terms, telemedicine, telecritical care, can you help our listeners understand really what's the difference between them? And then, sort of a two-pronged question, right? What impact does virtual health have on the bedside or direct care nursing ratios? Or should it? Right? So that's always the big question. If we have virtual health, do we take away from the bedside or is this a complement? So I'd love to hear your response.
Yeah, those are great questions. For the terminology, I think to put in our listeners' minds, picture a very big spider web and you're dropping names all throughout the spider web. The reality is, in the virtual world, a lot of this terminology is related to the other terminology in some way or form or fashion. For us, telecritical care, typically, much like what Julie mentioned earlier with one of her colleagues, does usually, if it's just the word telecritical care, it's more of physician focus. One of the models of either physicians round in response, where they will take on hospital admissions and then respond to any consult models, or something to that nature where it's just a consult based only. That's what we typically think of with telecritical care. And then you move into telecritical care nursing or tele ICU, then you start thinking of different models that involve more clinical expertise, nursing, non-nursing, and physician positions. But at the same time, you can say telecritical care, and that might actually be what they're thinking is a tele ICU version. So it depends truly on the hospital network or the group involved on how they're using the terminology. I know that doesn't really define it, but we're in the virtual world. I don't think we can specifically define anything like that. And then you look at eMedicine. Well, what does eMedicine mean? eMedicine, much like telehealth, is an overarching umbrella of a word. It means so much. So under eMedicine at UAB, we're talking about telestroke, teleneurology, telenephrology, telecritical care, teletrauma, telepsych, tele-ICU, virtual nursing, virtual sitters, remote patient monitoring. It all falls under eMedicine, but at another institution, it'd be called telehealth or digital health. So you start expanding those things. So it truly is, if you put a spider web out there and you drop a bunch of names on it, they can connect in some way, form, or fashion. It's usually just defined by the institution on how they're going to move forward with that terminology.
That was a great explanation. So obviously, given our focus here, we're focusing on the nursing aspect,
Mhm.
right? So when it comes to the virtual nursing, um, can you explain a little bit more?
Yeah,
And then there's where I kind of want to dive into a little bit about
ratios.
staffing and ratios. Yeah, 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 for sure.
Yeah. Well, let's start with that terminology again. So virtual nursing is the more widely accepted term for acute care virtual nursing. So following the medical surgical areas and the intermediate care and step down. So whereas some places will call it teleacute nursing, you can hear it called different things. Nationally accepted virtual nursing is the vernacular for the medical surgical acute care nursing. Tele ICU nursing, telecritical care nursing, that's usually more focused on ICU nursing or virtual ICU nursing. So that's one of the things that you do typically see a pretty divided line in that nomenclature there. With virtual nursing, though, it does go anywhere, and you know, we're talking now that places are going into virtual pediatric nursing, and you're looking at we've talked to people that do more of the mother baby and women's and emergency medicine and stuff like that. That stuff will also fall under virtual nursing in the beginning, but at some point in time, it'll get defined into something else. So it's
Mm.
just part of how that organic growth happens with our virtual healthcare world. But let's get more to the question that you wanted to talk about there when it comes to staffing ratios. I think first and foremost, what we want everybody to understand, Virtual healthcare is a tool to be utilized, not to replace. And it's the same thing when we start talking about artificial intelligence later on. It's a tool to be utilized, not to replace. If you're looking for it to be the solution, you're going to end up with the same challenges that you start with. You're running away from something rather than solving it. We see staffing is getting a little bit better a few years post-pandemic, but it's still a struggle in a lot of places, especially in our rural and community hospitals. So how does the virtual nursing help with that? Well, we mentioned it before. You guys mentioned it early on. Take some tasks off their hands. The most common thing that I would hear when we go to institute one of our programs is, well, I don't need virtual, I need physical hands. Reality is you're not getting them because there's nobody coming through the door to give you the physical hands. So why not use the next best thing? Someone who has your back can take some tasks off your hand and give you more time to put on those more focused tasks that you need, like your patient needs. So that's really where virtual nursing helps. It comes in to take time off the plate, tasks off the plate of our bedside nurses so that they can put more focus on their patient. That's the goal. And if I come in and I say, hey, listen, you've got 10 admissions coming in today, right? At an average of 25 minutes per admission, that's a lot of time, right? You're looking at what, 250 minutes there. So that's at least 4 hours that we're talking about of admission time. Well, if your ratio is 5 patients, you're down a nurse and you still have all that going on. If I give you 4 hours back, that's where you could take on another patient. And you're like, hey, I can take on a 6 patient ratio if somebody is helping take some of this time off my plate and I can just focus on those tasks there. That's a huge benefit. And that's where we started seeing a lot more acceptance of virtual nursing with our bedside teams when they started seeing that, opening their minds to what it does for them. And it's really been wonderful. That growth and acceptance rate has really started to climb.
That's the best explanation I think I've probably ever heard. And it also makes me think of, hey, the nurse can actually eat. They could get a meal break too. I mean, right? So thank you for that.
Absolutely. Yeah, I think that's one of the funniest things is when nurses say, I actually got to go to the restroom today.
And isn't that sad that that's what we have to say when we're like, oh, we got time back, we can go to the restroom. I also think about the extra time that I could be doing a complex wound care or things that take more time at the bedside with those patients. And that's what I think the beauty of using the virtual nurse to offload some of those tasks is pretty exciting stuff. Your program is pretty robust, and y'all have been doing this for a while. You've got rural, you've got, mentoring, you've got sitters. Why don't you just tell us a little bit about what the UAB's program is and how it's different from maybe other programs that implement telehealth?
Yeah, absolutely. I'll give you a quick journey of where we started with the virtual nursing part of things, starting with our tele ICU. So I mentioned I was brought on board to help build the team and build the program out. We opened on November 17th, 2020 with tele ICU. We started with 2 ICUs, and one of them truly, the ICU was opened due to COVID. It was a medical ICU that they expanded just to have take on the COVID patients. When we did that, it allowed us to monitor up to 47 beds. And you'll hear me use the word monitor and not watch. And I want to make something clear here. Even though those words mean similar things, they truly are different. Because if I'm monitoring, that means that I'm following the data, the vital signs, that patient-specific information. Watching means I have a camera on and I'm staring at somebody. That's a totally different thing. And we want to clear that up because that is a point of contention a lot of times when we get started. They're like, you're always watching me. No, I'm not. But we took that on. We said, okay, we're taking on these 2 units. What can we learn from this? We had partners that helped us develop the program. And we noticed within a few weeks, we were starting to show a lot of success just early on with what we were discovering, with the quality metrics, some of the culture changes that we needed to fix and work with and help develop with our partners at the bedside. We started to expand, and within, I'd say, 3 months, the powers that be came to us and said, we're seeing success with this program already in 2 ICUs at UAB. We need to find a way of bringing this to our medical surgical areas because they need just as much support, if not more, than our ICUs do. And we said, okay. It was relatively new. The virtual nursing programs were still kind of developing throughout the country. There wasn't one major company that had just a big hold on it. So we had to learn it on our own and develop based off what we had done with our tele ICU. We partnered with one of our med surg units and we just said, what do you need? What do you need help with? What is a pain point for you? And a lot of it came down to, the satisfaction scores, our patient satisfaction, our nursing satisfaction, our wounds, our falls. Can you help us with admissions, different things like that? And average experience at the bedside is less than 6 months. Can you help us with that? We said, sure. So we started putting it together. And oddly enough, with the recruiting that we did in our program, our average experience for the nurses here is well over 20 years. So when you bring that back, and we'll talk about that mentoring in a minute, that's a huge benefit that goes with those nurses. So we opened our virtual nursing program on April 20th, 2021, and we started with just one med-surg unit. Over the course of the next 4 years, we expanded both tele-ICU and virtual nursing to where we now cover 8 of the 11 ICUs at UAB. We cover 4 ICUs outside of UAB network for these 4 rural hospitals. We cover 7 med-surg and step-down units at UAB. And we've expanded those services to start covering admissions in our ED, discharges in the dialysis units, and a lot of different things. And we can talk a little bit more about specifics on those in a moment. But we kept seeing more needs of the virtual world because not only was there a shortage in staffing with nursing, we also saw that with our PCTs and our supplemental staff. Our PCTs were being pulled to be one-on-one sitters, and we were using a lot of contract sitter labor. And powers to be like, we have this virtual development program. How do we leverage it to help us here too? Because we need our PCTs working with patients, not sitting one-on-one. So we said, okay, let's take it on. Let's figure it out. And we developed a program that went live September 13th, 2022, where one virtual sitter would sit with 12 patients that could potentially return up to 12 PCTs back to bedside rotation. The goals there were to, again, return the PCTs, but also decrease falls across the hospital. And what we saw in 1 year is we were able to return 11,000 PCTs back to bedside rotation and decrease falls by 17%. And that's just in our first year. So we're like, well, let's expand that, take on 24 virtual sitter slots and then up to 36. And we just expanded to 48. So each thing just organically grows as we learn because we see more and more benefits. So that's just kind of a growth history of where we've been and what we've done over the last 5 years now, coming up on the start date of our anniversary of 11/17. But when we start looking at that, and I'm going to probably take you on a tangent for a minute. We instituted this during COVID. And, Julie mentioned this early on that it really exploded over the last few years, tail end of COVID and post COVID. When we brought it in during COVID, everybody's like, hey, this helps. We need to have connection with our physicians. They need to be able to get into these hospitals, into these rooms, but they can't physically be there. So using the equipment really helps with telehealth, bringing that in. Nurses, families, having those connections where you can't get in that physical room because of the nature of the disease. So yeah, we saw a great opportunity for growth. Then COVID ended. Not fully, but the waters receded and people wanted to go back to the way things were. They're like, oh, well, yeah, it was great then, but I don't need virtual coverage. I'm a great nurse. What do I need somebody in my room taking care of my patients for? I'm the one taking care of them. And if you're a nurse, the personality of nurses. We're all like only children. We don't like people in our room. We don't like people touching our stuff. So why are we putting more equipment in? And we started to realize that acceptance we had early on changed because people felt, well, I didn't really ask for this. It was thrust on me due to the situation. I don't really need it now. So we had to find a way of, yeah, all our data showed all the success. And that's great. And that's enough to keep a program running with the data. But when the frontline team is looking at like, I don't really use it. I don't really see the value. Maybe it'll help somebody else. That was a big warning flag to us that said, we're not relevant. We've got to find a way to make us relevant for that bedside person, to that bedside nurse, that bedside PCT, that bedside clinician. How do we really make it relevant for them? And the answer is we can't. We can't make it. It has to organically become part of their way of life. And so we started asking and listening, and what were the small things they needed? And it came to us, well, with the admissions and discharges was a big thing. We found out that in our emergency department, now UAB is a primary hospital in the state of Alabama where if there is a major situation when it comes to patient care, these patients are coming to UAB. We had a 50 something bed bay ED. It typically on an average housed about 75 to 90 patients. So we boarded a lot of patients. We still do. We found out that any patient that has been boarded, they're listed as an inpatient. They have to have their admission done. That is a joint commission standard. That's part of the way it has to be. They were having to pull float pool nurses off of the floors to come down to the ED and do admissions for all these patients that are sitting there. And that took resources away from our bedside team, which we already knew was running tight. When we found out about it, we said, listen, that's what we're here for. We gave them a couple of mobile carts and we told them, you just call us, we'll take care of it. We started that actually just recently in July of this year. And in our first month, we did 350 admissions for them. In 4 months, we've done over 1,800 admissions for them. That's insane. But the trickle down effect of that is what really makes me smile really big. Number one, nowadays, when our ED calls report to the bedside nurse, the first thing they ask is, has virtual seen them yet? That has increased our footprint across the entire hospital that has more than 54 units, and we're only in 15 of them. You got to think about that, right? That has increased that to where people are asking, not only has virtual seen them, but now they're coming to us organically saying, when can we get an admission card? When can we get a discharge card? When are you guys going to be installed in our unit so you can help us with all these programs and all these things? It's beautiful. But it took us taking a step back and looking at it and really looking at it, said, this hasn't been working for our bedside team the way we wanted to. How do we get them involved with it? And it really has changed. And now not only are we doing the admissions, we figure we can get them in. How do we get them out? So we do discharges. And if you've been at the bedside, whether you've been a patient, a nurse, or anybody there, you know that it's chaos. So if I'm a nurse coming in to give you your discharge education, reality is I have time to drop it off in front of you, get you to sign it, and walk out the door because I'm being pulled 40 different ways. But as a virtual nurse, you're my only patient. So I can camera in and I can truly make sure you understand what's going on with your care, how to take care of yourself at home, and make sure you have all those resources and it's uninterrupted. 30 minutes, 40 minutes, an hour, 10 minutes, however much time you need. We're starting to see the patients are more satisfied. They're more excited about knowing their care. They feel more confident in their discharge. And those nurses are starting to feel more confidence that they're using us a lot more. We're seeing satisfaction scores start to improve. We started changing the nomenclature of what we say to match a lot of these HCAHPS questions that they get so that that buzzword is said, that they understand it. Have you been told about your medication side effects? Do you know what your medication side effects are? Keep using that word side effects because that's the big word used, right? And
Mhm.
so they start recognizing these things. So all of it stems from just listening, and that trickle down effect has been massive. And again, it's a beautiful thing to see, and it really does make me smile, really big.
You know, Paul, I love how you've taken us on this journey of how you grew your program, but I think what you've also done is provided any of the listener a roadmap of how to do this and what to do in order to gain that buy-in. Because there's plenty of guidelines out there. There's the ANA Principles of Virtual Nursing. There's the AACN Telecritical Care Consensus Statement. There's the SCCM Expert Consensus Statement on Telecritical Care. And then there's the American Telemedicine Association Telecritical Care Guidelines as well. So there's all sorts of roadmaps to help you build your programs, but it's those nuances of how do I get buy-in and how do I find the outcome measures to that are going to make an impact. You talked about the scores and the HCAHPS scores and the patient satisfaction and the nurse engagement and the nurse satisfaction. And I think those things are so important in order to really help someone who's listening and thinking, I want to take this journey and what do I do? So kudos to you. So I'm going to throw it back to Andrea for just a second.
Yeah, you already answered the question that I was going to ask you, but it's made me think of a million more I could ask, and I could talk to you about this for another 3 hours, but we obviously don't have that time. But I do agree with Julie. I like how you found ways to evolve and grow. And when I think about the ER or the ED, I'm a former ED nurse, and the lack of discharges on the floor, everything rolls downhill, right? You can't get the patients out, there's no throughput. And I think about this boarding problem. It's national, right?
Hmm.
And I like how you're giving it to somebody else to do that admission. Because the reality is the ED nurses, their training is completely different, right? They're not even 100% aware of what to be asking, what they should look for. So I imagine that your outcomes for, let's say, completion of the admission properly or medication review, getting all the medications correct, I imagine those outcomes are better than if you're rushing through the admission on the floor, or the ER is not going to do it at all because they don't have the time, right? They're physically thinking about like treat and street, whether they're out the door or they're on the floor. And so I just, what do you have any outcomes that are showing better successes with more accuracy?
I think, anything that we do, it's hard to put a definite outcome early on. And,
Mm,
we started this in July and we're sitting in November, so only a couple of months worth of data there. But what I can attest to is going to be some of the satisfactions. We've been looking at, and I don't enjoy looking at things week to week. I prefer to
yeah.
see a little bit more, but that is something we promised, is that we were going to work on our HCAP scores for our virtual nursing units. We're seeing that the satisfactions are going up when it comes to these things. And I think that comes because communications early on. If you think about it, when virtual healthcare was first brought in, a lot of people thought, well, the masses, the community is going to be where the challenge is going to be, and the clinicians are going to be the accepting part of it. It really started in reverse because patients, most of the time, they're just happy that somebody is watching over them. So
Mhm.
having communication early on in the process, having somebody come to them, whether it be through a cart or an iPad or a camera with any AV technology, they come to them and they say, "Hey, listen, I'm going to go ahead and take care of all this clerical stuff for you. I'm going to get your information in. Just you and I are going to have this conversation. And then I'm going to have that done so that when your physical nurse comes up to you, they don't have to worry about all this stuff. It's just you and them, and they're focused on you." And we started seeing that deep breath, just kind of that relax of that anxiety, because nobody
Mhm.
enjoys being in the hospital. It's anxious already coming to the hospital. But the reality is, when you get admitted to a unit that already has a nurse that's got 4 or 5 other patients and they're taking care of them, they may not even know that you came to the door. So if you're
Mhm.
sitting there and you haven't seen anybody, even in 30 minutes, it feels like hours because that
Mhm.
anxiety's built up. Your room is cold. And that's what you really feel. That whole communication is cold. This unit is cold. But if you have somebody who pops in and says, "Hey, I'm Paul, I'm your virtual nurse for today. I'm going to go ahead and work through all this clerical stuff, your admission stuff, and get this stuff out of the way so that when Julie gets here, her focus is solely on you." Now, she is taking care of a couple other things right now. She's taking care of a couple other patients, but she'll be in here in just a little bit. If you need anything, don't hesitate to ask. Hit the button on your call bell there. And we're going to be monitoring your condition in the background. So if any emergency happens, we can reach out to your bedside team and get them in there immediately. And what we started seeing, like I said, that sigh of relief, that enjoyment, that smile on the patient's faces. So we did start seeing improvements in our patient satisfaction. The nursing satisfaction started coming when we started taking those tasks off their hands, and we started
Yeah.
seeing improvement in our nursing satisfaction. And those two, they run directly together. Because if you have a nurse that's even just a smidge bit happier, their care picks up because they show that warmth. They're not frustrated. They're not in a tizzy. They're able to work with that patient directly.
Mhm.
So it's all related. It goes back to that spider web. One little thing helps just shake the rest of the spider web, and that's big. So yeah, we have seen these things improve. Now, if anybody listening or any administrators are looking for a massive improvement in a short amount of time, I'm sorry, you're looking for the wrong solution. That's not what this is going to do. Just like anything, this takes small incremental improvements. HCAP scores, if you can improve an HCAP score by 4 points, that is massive. That is the world. 4 points doesn't sound like much, but that is the world. That's huge. And if you
Mhm.
consistently do that, I mean, you're really doing something big. We talked about just a moment ago, you were talking about, if you can't get the patients discharged and you can't get them out, Patients are going to sit in the ED because there's no room in the inn. It's just bursting. Well, we found that on virtual units, that when you compare them to sister units that don't have virtual care coverage, the length of stay on average is dropped by more than 5 hours. Again, 5 hours doesn't seem like much, but you put that on a 29 bed unit, that's 145 hours. You go over the course of a year, you're pushing over 10,000 hours on one unit, and that's 10,000 hours that a patient didn't have to be in the hospital. That's also 10,000 hours of patients not sitting in the ED. So it makes that big effect, but it takes time, and those numbers build up over time. So we have to remember that the littlest thing makes the biggest impact. The smallest catch makes the biggest impact. And that's what we want to start changing our way of thinking to. And I think we've said this in many conferences, many conversations, is it's virtual. It's the new interdisciplinary care. We have to change the way that we do care. We have to change the way that we think about it too.
Oh, absolutely. And, you know, there are so many ways this can go because I think about all the challenges in my previous organizations that I worked, trying to just get an admitted patient's medications reviewed, reconciled, and filled. And by the time 2 or 3 hours have passed and you don't even have your antibiotics yet. So I imagine just getting medications on time, getting them filled on time, or getting the discharge rec done and out the door faster, right? How every
Mhm.
hour you're sitting in the hospital extra, you're at risk for infection, you're at risk for a problem. So I just all of this is such a benefit that rolls down into other things. And you've just done some fantastic work, really.
They really have. If we have time, Andrea, I'd like to just address the mentoring a little bit more,
Please go
because
ahead.
because Paul, you talked about the nurses that you've got working in your virtual have like 20 years of experience, and that they can mentor the nurses who are on the floor who have less than 6 months of experience. And I was really happy to help your tele ICU manager, William Jones, get his blog
Uh-huh.
published, because he wrote such a good blog where healing still happens. UAB's tele ICU offers nurses a lifeline back to the profession, and that's available on aacn.org, and it's such a great story about how those nurses are still engaged. And part of what was in that story was stories of mentoring. And so if you could give us just one or two examples of how you've seen the virtual nurses or the tele-ICU nurses mentor the nurses who are newer to the care of taking care of patients, I think our audience would just love to hear that.
Yeah, absolutely. Yeah, I've got actually the perfect example. Our very first night open. So when we first opened, we are a 24/7 model, 365. We're essential employees. It doesn't matter if it's good weather, bad weather. We're in Alabama, tornado weather. We don't get snow, anything like that. We're here. So we are supportive of our bedside team. Our very first night open, November 17th, 2020, that COVID ICU unit had a brand new nurse. The nurse was just off orientation. They had amazing training. They trained with the medical ICU team, which is a fantastic team. But let's sit it in reality that this nurse was in a COVID patient's room. The patient was fighting the ventilator, so they weren't completely with it, but their body wasn't accepting the ventilator pressures and everything. So they had a heart rate was through the roof, respiratory rate was through the roof, but their blood pressure and the oxygen levels were dropping. The nurse had done everything they knew what to do, but this is a first experience for them. They're inside the COVID room, so they can't just walk out, scream for help. So they look over and there's a big green button on the wall. They press that button on the wall, and one of my nurses that has over 20 years experience cameras in and says, "Hi, I'm the tele-ICU nurse. How can I help you?" And the nurse says, "Listen, I've done all these things. I don't really know what else to do. Can you help me?" And the nurse said, "Sure." Pulled up the patient's chart, looked through the chart, looked at the medications, looked in the room. And what they saw was an IV medication set up for that patient, but it was going at the lowest rate, the initial rate. She looked at that, looked back at the chart and said, "Hey, this is what this medicine is. This is how this medicine will help your patient. And these are our titration parameters. I'm going to stay engaged in this room with you until we get this patient back to even." 15 minutes later, that patient had calmed back down and they were resting comfortably. Heart rate was normal, respiratory rate was normal, blood pressure, oxygen, all that was normal. So the patient was having a good night. The nurse no longer pulling their hair out, so they're not going to look like me in a few years. They're having a good night. And this is truly what the mentoring brings, is we're able to help in those situations. Because I honestly don't know a nurse that has ever gone through an entire career that didn't walk into a room one day and say, I just cannot put my finger out, but something doesn't look right. I need a second set of eyes. And that's really how this built up. Then when we started building to our acute care area and doing the virtual nursing, we said, well, listen, you're hiring brand new grads right out of school. They're going to be nervous going in for the first time. Why don't you hit the button on the wall and have us do their first assessment with them? That way they don't necessarily have their preceptor standing right there. They can ask us anything that they need, but we're not going to interject. We're just there to support them. And that started building a little bit more of that orientation support. And then it just it blossoms, naturally into other things, organically into things like, I don't quite understand this medication. Can you help me with this? Or, hey, I've never really started an IV in this area. Can you help me with this? Or, I don't understand how to flush an art line, which we started getting with our rural hospitals because they didn't use them before. And now because they have tele-ICU support, they get to. So we get to walk them through these things. Same thing with ventilator management and all these different tools and things that they weren't using before that they're all now using. Well, the nurses in the tele ICU, they have an eclectic mix of skills: cardiac, neuro, surgical, trauma, burn, chemotherapy, name it. They've experienced it. So they're there to support. And it's been a huge tool. What we started seeing from when we went live to now, on average, the vacancy rates on the units that we cover have all dropped by 17% or more, which is huge. That's
Wow.
a big, win, because now you have nurses that are staying on those units and become the elder statesmen on those units. They know their units now. And it's just that working together, that partnership has been huge. That's truly when we say mentoring, it just covers all the little things there that just build confidence so that they start teaching each other. One other example I have before I cut off the mentoring part of there or in that question, but we do full rounds. We mentioned our model before, and I guess I should have started with that, and I can go into that in a moment. But part of that rounds, every patient, every shift, we're going to do a full chart review. And in that, we're looking at orders, progress notes, admission notes, procedure notes. We're also looking at labs, vital signs, trends, things like that. And on our virtual nursing side, we saw a low bicarb on a patient. The bicarb, I think, was 13, and which is very, very low. It's not a good number to have. So I saw it come across, and I reached out to my virtual nurse, and I was like, well, did you talk to the nurse about that? And they said, well, I will. And they called to the nurse and they said, hey, listen, I saw this bicarb. I don't know if you've seen it or if you've had a chance to address it, but would you like me to call the doctor and get some treatment? And then the bedside nurse was like, well, what do we really need that for? And so my nurse walked them through, what that bicarb number means, what all system it affects, what it can do, what we should look for. And the nurse is like, oh my gosh, I didn't realize that. Will you reach out to the doctor? Perfect. The next day, same virtual nurse, same unit, different patient, had another low bicarb. And I reached out. I was like, well, did you reach out? Yeah, I actually reached out. It was the same nurse. And I asked if they wanted me to call. I said, no, I've already done it. And this is the things we're doing. Like, boom. And now you're starting to see a change in the culture of we know what to look for now. Thank you for that. And it's just that one little nugget of information just started that cascade of, oh, I can look for these things in that newer nurse. And it also happens with those experienced nurses that during COVID just got into a rut of doing the same things that weren't doing before. You start changing that culture of looking for those quality things. It's amazing to see that. And again, I keep using the phrase organically, but it's when that happens organically, that's when that light bulb goes off and that partnership truly melts.
That's so exciting. That's just absolutely so exciting.
I did want to touch
We
on something though that you guys asked if it's okay. You mentioned the different models and you asked me to go through that, and I didn't do that before. I kind of jumped around. I think that is something that we should touch on. When we talked about virtual nursing and tele-ICUs and how they've been around since the late 1990s and early 2000s, there are so many different models and so many different designs to it and staffing models to it and what it does. There for the nursing portion of it, there is the really kind of a task-oriented setup to where the nurses just fire off on tasks. That's all they have. Then you have those models that they only wait for people to call into them. And then you have that continuous rounding model. And that's more of what our model is. You have those models that are going to be a couple of shifts on the floor and then a shift inside the tele-ICU operations center. You have the work from home models. There's a lot of different stuff that goes on. So when we built our design, we built it with a purpose of we are a locked unit. So we're not going to float to the floor and we're not going to have floor nurses float into us. We hire for our team, and that's the team's going to help cover themselves, right? Even when we expanded from tele-ICU to virtual nursing, we trained everybody across the board to cover everything. When we expanded to virtual sitters, it's the exact same thing. So that if we have a call in or we're short, we cover internally and we take care of that. That model also expanded to where one virtual nurse monitors up to 48 patients so that they have more than one unit. It's kind of fair across the board. It can be more than one hospital depending on how we're set up. And what they're doing truly is full rounding with purpose. On each patient, they do a full, like I said, chart review where they go through, they round, they look at the admission notes, progress notes, physician notes, all of it. And they take those notes and they match them to the orders. Because just like nurses, physicians get wildly busy too. And sometimes what they put in their notes don't transition over to the orders. So they make sure those match up. And then after they've done that, they do a video assessment on that patient and they make sure what's being done, the care inside the room, is matching what the orders are. So that it all comes together to be the same thing. After they've done this on each patient on that unit, they put together an email. We call it this possible needs email. And it comes with the idea of this. In a perfect world, we have charge nurses or assistant nurse managers, shift leads out of staffing, and they're doing chart reviews on every patient on their unit. And then they're going to each nurse and patient on their unit and making sure that all those quality items are taken care of. We've said it before, we all know it. This isn't the perfect world anymore. And it's rare that the shift lead, charge nurse, or assistant nurse manager is out of staffing and just able to do that. Most of the time, they're taking on a patient assignment. And if they're not, they're mentoring and putting out fires throughout the entire shift. I mean, we realize that. So why make them do that if we're already in the chart? So we narrow it down to a few things that raise a little bit of a red flag for us or some of those quality items, and we put it into that email so they have a focused set of things to look at. And it's with the intent of you may have already seen this or maybe you haven't. But if you haven't been able to address it, you haven't seen it, here are some things that we saw. Maybe that helps, tighten things up for you. And what we saw immediately was one of two things. Either the competition of they just didn't want to see those things on our email, so they jumped in and started doing it before we sent the email, or we saw where they started taking that email as a guide and saying, hey, these are some ways that we can improve our care. Either way, you're changing the culture at the bedside for the better. And we started seeing improvement in our patient outcomes. Now what happens is those units come to us and say, hey, can you add these things to the email because we're having pain points in this area? Hey, we're noticing that our ventilator orders are not matching up to, the treatment plans that our doctors really want. Can you make sure that we have those in there? Absolutely. And now each unit is like an independent hospital for us. We tailor it specifically for them. And it's been wonderful. And that truly is the model that we brought out and that we focus on. And I think all the different models out there have their merit. And I'm not going to say one is better than the other. It's just what works for the group that they're utilizing and what benefits the bedside team. And for us, that's the model that's worked. And it has been fantastic. We did have
That's
people in
neat.
the beginning say, oh, I'm sorry, go ahead.
I just said that's neat. And I know we're coming close to our time. So I want to ask you a question
Oh,
about your
yeah.
rounding. Is because I know people are gonna ask this question is for your nurses who are rounding, your virtual nurses who are rounding,
Mhm.
how many patients do they round on? So like what's that virtual nurse to patient ratio
Yeah, up to 48 patients
to
each.
48? Okay.
Yeah. And,
And
when
in
we
what time frame is that? Like are they working a 12-hour shift?
They do. They work 12-hour shifts. That's what I was going to say. That's one of the differences. At the bedside, coming as an ICU nurse, you give me two patients, I got this. You give me three, I can rock that. You give me four patients, it's going to be a minute. I'm an ICU nurse. I haven't done four patients in a while, right? So when we said 48 patients, we're like, wow, that's a lot. But there is a reality of, first off, we've got 12 hours to do this. And second, we have the uninterrupted time where we can put that focus in. So once we started doing that, we started seeing in the first 4 to 6 hours of the shift, we do that first set of rounding. We're able to get through it in most cases, and then we come back in the afternoon or in the morning, whichever our shift is, and we do a second set of rounds just as a follow-up. Did I miss anything? Did these things get addressed? How can I help out? Are there patients that are a little sicker that need me to round on them a little bit more? And organically, again, it started changing and evolving from where we started. It it really is. It's a wonderful system for us.
That's neat.
How many nurses do you have working at the same time? And if some are rounding, are others focused solely on admits and discharges? So if you're staffing per day or staffing per shift, what does that look like for somebody who might want to be interested in setting this model up? That
Yeah,
didn't
that's a
make sense.
great question. Great question. Right now, with all the coverage that we have upwards of 25 nurses with a couple of non-nursing positions each shift. And with that, it did organically kind of grow into separate types of nursing stations. So our station nurses are the ones that do the 1 to 48 rounding on all the patients. We have leadership on the unit just like a bedside does. So assistant nurse managers or charge nurses, shift leads, whatever it's called. We have those on each unit. We don't call them out of staffing because they cover everybody. We typically will have a float nurse that will help with the smart predictive alerts while people are rounding and help with some of the sicker patients. And then we have a discharge nurse. Their focus is mainly discharges and assisting with admissions. And since we've created this ED admissions nurse, that program, because it just took off, we have an admissions nurse every shift as well. But even though we have designated stations and designated positions, the entire team is responsible and covers. That's the reason why we decided not to do the work from home model. Inside the operations center, when we're here, everybody has a buddy. We have a buddy system. Everybody covers everybody. Everybody learns the entire program so that each person can step in. And it truly does. We mentioned it earlier. When one of the biggest focuses, I got a restroom break today, there's no reason somebody doesn't get breaks and lunches and those things inside our operations center because there's always somebody to back them up. And it's wonderful. And just like anywhere, in the beginning, they're like, oh, I got to take this on. Within a week, they're like, yeah, not a problem. I got you. And they're taking it on and just it expands on them. And they bring it to us and they say, hey, can we change and do some of these things? We're like, let's give it a try. It truly is. They take ownership and it's fantastic.
I am just blown away by your model and how it has grown and everything that you're doing. The collaboration is fantastic because I cannot imagine the support that the bedside nurses must feel, and especially with so many young nurses and I don't mean young in age, right? I just mean young in experience, that the support that they're getting and this mentoring that you have is so great for the development of critical thinking and for them to be able to apply all the things they learned in school, like truly at the bedside and see that evolve. Like the story about the bicarb is just fantastic. If I didn't live where I live, I think I'd come work for you.
Yeah.
Like, this is great. I mean, truly great. And I can't imagine the time it gives the nurse back to do the wound care, the turning, proning, whatever it happens to be. And I just think it's fantastic. And I really, really would love to thank you for your time today. Your expertise, your experience, and sharing that with all of our listeners is just really fantastic.
And your enthusiasm is contagious. I would love to work for you, Paul. I mean, honestly, your enthusiasm is contagious. So thank you so much for being our guest today.
Well, thank you guys so much. Yeah, I love what we do. And yeah, I guess it does come out when I talk about it, but it's amazing. And we're just starting this journey. Virtual healthcare has got so much left, and I'm so excited to be a part of it. So yeah, thank you guys for letting me come and talk about the things that we do here. And anytime I get an opportunity to do that and brag on my team, I'm happy to do so. So thank you guys so much.
You're so welcome. And I hope our listeners found today's episode beneficial and that there's something that they can take away and bring back to their organizations. And as always, for our listeners, we welcome feedback on this episode and any ideas for future episodes. And please send your feedback to podcasts@aacn.org.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by AACN's award-winning online leadership course, Fundamental Skills for Nurse Managers, with information available at www.aacn.org/manager skills.